Hey future doctors, today we are going to see about anti-tuberculous drugs. So this is divided into two things, first line drug and second line drug. Now in first line drug there are isoniazid, then rifampin, niamide, then ethambutol and streptomycin. You can remember this by the help of FRIST. In second line drug, they are divided into three types, fluoroquinolones, other oral drugs and injectable drugs. Now in fluorofloxacin, then levofloxacin, moxifloxacin and ciprofloxacin. You can remember this by old lungs move circularly. Then oral drugs, so that is ethanamide, then prothionamide, then cycloserine, terizidone, para-aminosalicylic acid, then rifabutin and acetozone. Then in injectable drugs, there can be kanamycin, amikacin and capreomycin. You can remember this by keep all caps. And you can remember other oral drugs by every pro can treat persistent respiratory TB. So this was all about classification of anti-tubercular drugs. Now we are going to see about isoniazid. So it is also known as INH, that is isonicotinic acid hydrazide. So the mechanism of action of isoniazid is it will inhibit the biosynthesis of mycolic acid, which is essential for the mycobacterial cell wall. Basically, isoniazid, it will act as a prodrug and it will inhibit the mycobacteria by converting to the active form, and then it inhibits the synthesis of mycolic acid, which is a component of mycobacteria cell wall, and the death of bacteria will occur. Now we are going to see about pharmacokinetics. So INH, it is readily absorbed from the gut and it is distributed all over the body, as well as tubercular cavities and body fluids such as CSF and across placental barrier, as well as it is metabolized by the acetylation and metabolites are excreted in the urine. So this was all about pharmacokinetics. Now we are going to see about uses. So it is a first line drug which is used for the treatment of TB, as well as it is used as prophylaxis for TB. Then adverse effects. So first is hepatotoxicity. So the risk of hepatic damage, it is more in the chronic alcoholics, elderly patients and rapid accelerators. Reversible on discontinuation of the drug, and patients receiving INH should be monitored for symptoms like anorexia, nausea, vomiting and jaundice. Then second is peripheral neuritis. So it is the dose related toxicity. So isoniazid, it is structurally similar to the pyridoxine, and INH, it will competitively interfere with the utilization of pyridoxine. And other side effects are fever, skin rashes, arthralgia, anemia, GI disturbances, rarely convulsions. So these are some effects of isoniazid. Now we are going to see about rifampin. So rifampin, it is a derivative of rifamycin, which is a first line anti-tubercular drug, as it rapidly kills intracellular and extracellular bacilli. So now we are going to see about mechanism of action. It will bind to the bacterial DNA dependent RNA polymerase and it will inhibit the RNA synthesis. As well as rifampin has a bactericidal effect against the mycobacteria and meningitis, H. influenzae and S. aureus and E. coli, Pseudomonas and many more. It is given orally and it is rapidly absorbed from the GIT, but the presence of food reduces its absorption and it is distributed widely over the body and it will get metabolized in the liver. Now here are some uses. So first is tuberculosis. So rifampin, it is used along with INH and the other anti-TB drug for the treatment of TB, as well as it is also used as chemoprophylaxis of TB. The second is leprosy, and third is prophylaxis of meningococcal as well as influenza meningitis. So rifampin reaches the high concentration in nasopharynx and eradicates the carrier state in the case of meningococcal and H. influenza infection. Then fourth is rifampin in combination with the beta-lactam antibiotics. It can be useful in staphylococcal infections such as endocarditis or osteomyelitis. Then rifampin, it is also used with the doxycycline for the treatment of brucellosis. Adverse effects. So first is hepatitis. The main adverse effect and the risk of hepatotoxicity is more in alcoholics and elderly patients. Now flu-like syndrome with the fever, chills, headache, muscle pain as well as joint pain, all this will occur. And then GI disturbances such as nausea, vomiting, abdominal discomfort. And fourth is skin rashes, that is itching and flushing. So these are some adverse effects. Now we are going to see about pyrazinamide. So it is a synthetic analog of nicotinamide and it is active in acidic pH, as well as it has tuberculocidal activity. Pyrazinamide inhibits the mycobacterial mycolic acid biosynthesis but by a different mechanism, and it is given orally, which is absorbed well from GIT and distributed widely throughout the body including CSF, as well as it is metabolized in the liver and excreted in the urine. Now here are some adverse effects. So first is it is dose dependent hepatotoxicity, and second is anorexia, nausea, vomiting, fever, skin rashes, all these things will occur. Next is ethambutol. It is also used as a first line anti-TB drug. It will inhibit the arbitazole transferase which are involved in mycobacterial cell wall synthesis. It also has bacteriostatic drug in combination with the other anti-TB drugs to prevent the emergence of resistance, and as well as it is well absorbed after the oral administration and it is distributed widely in the body and it is metabolized in the liver and it will cross blood-brain barrier in meningitis and it is excreted in urine. So this is to see about adverse effects. So first is optic neuritis, adverse effect which is seen with the ethambutol, and this is characterized by decreased visual activity and color vision defects. So basically red and green defect will be there, as well as nausea, vomiting, abdominal pain, skin rashes, itching and joint pain, this will occur. Now last is streptomycin. So it is an aminoglycoside antibiotic. It is also bactericidal drug which is active against extrabacillar bacilli in the alkaline pH, and streptomycin, it is not effective orally and it will be injected intramuscularly. So basically of administration of this is IM, that is intramuscular. Then adverse effect of streptomycin is ototoxicity, nephrotoxicity and NM blockade. So this was all about the first line anti-TB drugs. Now we are going to say about treatment. So WHO recommends MDT, that is multiple drug therapy, for all cases of TB. The objectives of MDT are to make patients non-infectious as early as possible and decrease the transmission of disease, as well as to prevent the development of drug-resistant bacilli, to prevent relapse, and to reduce the total duration of effective therapy. Now we are going to see about RNTCP. Now what do you mean by RNTCP? It was a guideline which was given in 2016 for the TB. We are going to say about the type of patient, intensive phase and continuation phase. So if there is new patient, then in the intensive phase we can give 2 HRZD. So this is basically a drug regime which can be given in intensive phase to a new patient. Now for HRE in the continuation phase. Now what do you mean by HRZD and HRE? So H means isoniazid, R means rifampin, S means streptomycin, Z means pyrazinamide and E means ethambutol. And this is previously treated patient. So here we give 2 HRZD plus 1 HRZD and in continuation phase we give 5 HRE. So this was all about RNTCP, that is Revised National TB Control Program. Now we are going to see about drug resistance. So basically first is monoresistance, where are resistant to only one first line anti-TB drug. The next is polydrug resistance. Here the bacilli, they are resistant to more than one first line anti-TB drugs, but not both INH and rifampin. In MDR, that is multi-drug resistant, here the bacilli are resistant to both isoniazid and rifampin, okay, with or without resistance to any other first line anti-TB drugs. And next is XDR, a TB case with the bacilli being additionally resistant to a fluoroquinolones or second line injectable anti-TB drugs such as amikacin, kanamycin or capreomycin. So this was all about anti-TB drugs. Now we are going to see about multi-drug resistant TB. Now MDR TB can be treated by either standard or individualized regimes, and drug sensitivity testing should be done for all patients. As well as patients with highly likely to have MDR TB should be treated with regimens containing at least 4 drugs, to which additional to this pyridoxine, it should be also administered to the patients with MDR TB to prevent the neurotoxicity due to ethanamide and cycloserine. Standard treatment regime for MDR TB. So first is intensive phase, that is 6 to 9 months. Here the drugs given are kanamycin, levofloxacin, ethanamide, cycloserine, pyrazinamide and ethambutol. As well as pyridoxine is given, which can prevent the neurotoxicity. Drug given is 100 mg per day. The next is continuation phase, that is of 18 months. Here the drugs are levofloxacin, ethanamide, then ethambutol, cycloserine and pyridoxine, that is 100 mg per day. So this was all about anti-TB drugs.